I'd like to introduce Dr. Joe Wildenberg as our speaker today. A little bit of background about Joe. He obtained his bachelor's degree from the University of Wisconsin-Madison, physics, mathematics, and molecular biology. Was that a triple major, really?
It was. I'm a huge nerd.
Okay, he continued his studies at Madison. He earned his PhD in neuroscience from Madison in 2010, and then his medical doctorate degree from UW-Madison in 2012. After that time, he spent a little bit of time in Oregon, and then a more significant amount of time at the University of Pennsylvania, where he, and I'm going to list off some things that he did, he was an informatics fellow, an interventional radiology fellow, diagnostic radiology resident, and chief research assistant, all during his time at the University of Pennsylvania. He then returned to Wisconsin. I guess he grew up in Eau Claire, so he returned to Eau Claire to take a position at Mayo Clinic Health Systems in Eau Claire, where he is now an interventional radiologist. The title of his talk, you can see it up there today, is about artificial intelligence augmenting the physician's role in improving patient care. So I'll turn it over to you, Joe.
Thank you, Mike, so much for the introduction. Thank you all for having me today. It's really a pleasure both being back in Eau Claire as well as here at UWEC. There's been nothing but amazingly positive changes, I think, over the last 20 years, and to be back and be a part of it is really flattering and amazing on so many levels. So I've been fortunate enough in my sort of brief career as a physician to not only see a lot of the medical side of things, but also be involved in some research in artificial intelligence. And I just wanted to talk a little bit about kind of where I think we stand in terms of how AI is incorporating itself into the medical world. What are some things that are maybe a little bit more hype than reality, and where we can kind of go from here to hopefully actually make that a reality and truly improve care for patients as we go forward. I don't have any financial disclosures, but I do want to point out two things kind of related to this talk overall. I do a little bit of research in this field, so of course that means I'm going to have my own biases associated with that. And most importantly, while I am employed by the Mayo Clinic Health System, the things I'm going to say today, the views I'm going to express really are my own and not necessarily representative of the overall Mayo enterprise. So take that for what you will. Kind of a big picture outline of what I want to chat about, just a little bit about where we got, or how we got here in terms of the hype of artificial intelligence in general, where that stands with regard to AI in medicine, what it might look like in terms of its integration with physicians and other healthcare professionals, how sometimes what you read about in the big news media might actually be a failure kind of masked as a success just to gain some notoriety. What are some challenges going forward? And then I wanted to end with just my own perspectives about what AI really needs to do to truly succeed in the medical field in really a way that I think might be unique compared to some of the other areas of where it's integrating itself. I think really the time when AI kind of met the national stage and had its coming out party was with IBM Watson back in 2011. I'm sure many of you probably remember when it was so successful in winning Jeopardy. And I think a lot of that success had to do with it emphasizing and finally integrating a couple different techniques that had been around for a while, but maybe people really didn't realize were starting to become kind of commonplace. And those two things were a hierarchical knowledge base, where a machine could actually start to learn like a human being, where low-level facts were integrated together into mid-level facts, and finally into big-picture concepts. And of course, natural language processing. Natural language processing is really important for computers because that is how we all communicate with each other. We do that whether it's be in visual language in terms of the written word, obviously speech like we're doing right now. The ability for a computer system to actually parse that and integrate it, I think, was vital to IBM Watson's success and really started allowing the average person to understand what artificial intelligence might be able to bring to the table. And I think it did generate a huge amount of excitement about AI. Before this, I think AI tended to be more in the realm of the science fiction writer, people who were proposing what some undetermined future might look like, or of course those who were in the field actually doing that research. But all of a sudden, the average person who maybe had no familiarity with AI was starting to think about how it might impact their daily life. Even before that, however, there were some successes that I think actually made quite a bit of news. Back in 2005, DARPA had its second grand challenge. And for those of you who are familiar with it, it was basically a challenge to really anybody out there to develop an autonomous vehicle that could navigate its way through a desert obstacle course without any human intervention whatsoever. And even back in 2005, a team from Stanford developed this Volkswagen SUV called Stanley that was able to successfully create that course, or successfully navigate that course, I'm sorry. And of course, in 2014, we had the release of Waymo and its iconic kind of bubble car that was supposed to revolutionize autonomous vehicles, self-driving vehicles, however you want to call it. And even back in 2015, Wired had this nice headline saying that Tesla cars can kind of drive themselves. And as you guys know, despite this being 4 or 5 years ago now, we are still waiting when it comes to self-driving cars. This was just an article from a couple weeks ago where people within the field are still frustrated because Tesla is advertising its autopilot feature that's just not ready for prime time. So a lot of times we see this over and over again where there's this hype of artificial intelligence, but we're still kind of left waiting, even years and sometimes a decade after we first get a glimpse of what it might look like. And of course, it's not unique to the self-driving car world. In medicine, back in 2014, again from Wired, and sorry, the text is a little bit small, Wired asked, well, is artificial intelligence now telling physicians how to treat their patients? From the same year, the New York Times kind of waxed poetically about when are physicians going to be completely obsolete and be replaced by these artificial intelligence algorithms. And to bring something a little bit closer to home, I wanted to talk about this gentleman named Dr. Ezekiel Emanuel. He is a physician who actually was instrumental in the design and the passage of Obamacare. And regardless of your feelings about that particular piece of legislation, he is an absolute expert in the field of how healthcare systems work together, how computer systems might become involved in that and actually augment different healthcare providers. And he stepped into the lion's den. He went to the American College of Radiology's annual meeting and basically said, all of you are going to be unemployed in 5 years. Now, of course, he didn't quite say it with those exact words, but he did imply that people who interpret images for a living, artificial intelligence is going to be able to take their jobs. And that was back in 2016. On a more personal level, in 2014 really, I actually saw this guy speak in person. And he said, I don't know why anybody would go into radiology. By the time that they finish their training, there's not going to be any jobs available. And as somebody who was going into radiology when I heard that talk, you can imagine that that was a little bit nerve-wracking for me. A little bit, my feathers were a little bit ruffled, but of course I was just a little bit like, well, who is this guy and what is he talking about? Now, I can rest assure you I'm gainfully employed as a radiologist, so his ideas have not quite come to bear at this point. But he's a really smart guy, and I don't want to dismiss some of the ideas he has. And I really do think that artificial intelligence is going to start to play a role. So a little bit, as we go forward, I want to talk about how that might happen, what that might look like, and where some of the challenges might arise. So before I get there, I wanted to step back and say, why do we hear so much about artificial intelligence in radiology or imaging in medicine in the first place? And I think to start out with, we all know that vision is our kind of primary sense. We get more information through our eyes than we do through the rest of our senses combined. And that makes us very familiar with that concept and offers up a huge area of familiarity when we're doing this type of research and developing this type of technology that we can draw upon. Additionally, there are a huge number of medical examples that we see in everyday life where artificial intelligence is actually dealing with imaging. Every time somebody posts a picture to Facebook right now, a Facebook artificial intelligence algorithm will process that image and look for a face. Once it finds a face, it will use another layer of its artificial intelligence algorithm to try and incorporate who you are, who you usually take pictures with, what the facial features are of that particular face, and try to recommend, well, who is that person? Is it one of your friends? Is it a celebrity? Is it a relative? What kind of facial information can be extracted from that? Because we see this already in our daily lives, it's very easy to make the next step and say, well, of course that's what it's going to do in a medical field. Take imaging, interpret that image, and make a decision based on it. Additionally, somewhat unique in medicine, radiology images are a little bit self-contained. This is an MRI image of a brain right here, and it really contains all the things we need to know about the anatomy of that patient, specifically the anatomy of that patient's brain. This is different than other aspects of medicine. When you go visit your physician's office, you probably fill out a questionnaire when you get there, and that goes into one part of the medical record. Then you see a nurse or some other person for intake, and they take your vitals. That goes into another part of the medical record. Then you talk to the physician or nurse practitioner, and that goes into another part of the medical record. And all those areas are admittedly very difficult to integrate together. Difficult for a human and certainly very difficult for a machine. But here it's all self-contained. And even more than that, radiology images are associated with a ton of metadata. And I know you can't read all of this right now, but this text data is actually packaged together with the radiology image. So it's very simple to just stick an artificial intelligence algorithm on that image and say, go. What can we learn about it? What conclusions can we make about this radiology image? So all of this gives it a little bit of an advantage over the rest of kind of the medical record and the medical data that we generate. And additionally, frankly, a lot of medicine is imaging. Of course, radiology is the one that most people think about, but pathology, looking at cellular slides, now almost all of it's digitized, so it's just an image no different than a radiology image. Dermatology, looking at a skin lesion. Well, a lot of times those are actual images that are captured and put into the medical record. Even ophthalmology. When an ophthalmologist dilates your pupils, looks at the back of your retina, that's an image of the retina that can be stored, processed, interpreted, and some conclusions drawn about what actually might be going on with that particular patient. So even though radiology might be the poster child for what ends up happening with imaging in medicine, I think there are a huge number of specialties that are all grouped into there, and that's why it's a natural target for these artificial intelligence algorithms. But I don't want to give the impression that AI is only looking at imaging when it comes to medicine. This is a study from one of the common medical informatics journals that talks about using an artificial intelligence algorithm to actually monitor for prescription errors. By looking at what patients are commonly prescribed by particular physicians, what a pharmacist commonly administers for the particular disease process that's going on there, this algorithm tries to say, well, this looks like it's a little bit of an outlier. Maybe it's an actual medication error rather than the intention of the physician or the intention of the pharmacist. Similarly, there's algorithms that are trying to predict before a patient has surgery which ones might have a less ideal outcome. And that would be important for both the surgeon and the patient to have that information beforehand so they can have a better discussion and more appropriately weigh the risks and the benefits of going forward with that surgery. All of these things are ways in which AI might be able to get its foot in the door and actually contribute to patient care in a way that's going to be productive. All of the things I've talked about so far, whether it be imaging, analysis, or these two examples right here, are kind of retrospective analyses that AI might be able to do. But I don't want to limit it to that. AI can work in real time to actually improve patient care as well. This is an anesthesia cart that anesthesiologists use when they put somebody to sleep when they're going to have a surgery or some other procedure. And the interesting thing is, it also is completely self-contained, or nearly completely self-contained. It has almost all the medications that an anesthesiologist is going to use to help that patient be comfortable. It also has almost all the recording equipment that the anesthesiologist is going to use to monitor the patient and make sure that they're doing okay. And in fact, it's actually directly integrated into the medical record. So all the inputs and all the outputs are all right here. Now, I know you can't see any of that, and that's actually intentional. I don't want you to waste time kind of trying to see all these little dots. But it's organized in a very straightforward way. There's an output section with all the measurements: blood pressure, temperature, respiratory rate, all those sort of things. There's an input where all the drugs that are going in, the vent settings to help the patient breathe at a steady rate, go in. And really what the anesthesiologist does is connect these two. They look at the outputs, they interpret it, and then they appropriately change the inputs to make sure that that patient is right where they need to be. Well, as you can imagine, that is the perfect place for artificial intelligence to have an algorithm to augment and help that anesthesiologist do things in a more stable and rapid fashion. And there's no reason that there has to be a delay between this. This algorithm can be doing it really as we go and helping that patient, again, sort of stay at the right spot. And even that can happen within the surgical realm. I'm sure almost every single one of you has now seen advertisements out there for robotic surgery. Hospitals advertise that they have a robot that can do these surgeries. Well, the important thing is that it's not really the robot doing the surgery, it's the surgeon here, if I can get this, sitting separate from the patient and controlling the robot. Now that surgeon may be 10 feet away in the same room, but sometimes it can be 100 miles away or 1,000 miles away in a different part of the country. And just like with the anesthesiology cart, that is a natural input and output where an artificial intelligence algorithm might be able to augment the surgeon and try and help them do their job a little bit better. And of course, a surgeon in the room is going to say, there's no way that an artificial intelligence algorithm can help me do my job or do my job for me. They'd say, surgery is too complex and there's no way the algorithm can recognize what I'm seeing in this, in the little scope right there. How could that possibly happen? But I'd argue that technology from other fields is already there. The self-driving car world is a perfect example. In real time, those algorithms are identifying from a visual image different things that are moving. They're saying, this is a car, I need to be careful about that. This is a person on a bike, I need to be really careful about that one. And that type of technology can be applied, in my opinion, almost identically to what the surgeon is seeing in their scope. Here's an image of a patient getting their gallbladder out, a cholecystectomy. And there's no reason that that artificial intelligence algorithm can't do the same thing that the self-driving car algorithm is doing to separately say, this part is the liver, this part is the gallbladder, this part is the omentum of the bowel, and appropriately go after the gallbladder to take that out while leaving all the other ones untouched. So I'd argue that really, even though imaging is kind of the poster child, as I mentioned before, for where AI might come into play, there are a huge number of avenues for which artificial intelligence can start putting their foot in the door and helping all medical professionals really give those patients better care. I wanted to talk about real briefly a project that I've been working on because I think it highlights more importantly that the term artificial intelligence goes above and beyond what we really necessarily need to do. So I do work on in what's called inferior vena cava filters. These are little like badminton birdie looking devices that sit in a vein and prevent a blood clot from going to the lungs. They work really, really well. The problem is that they sometimes work so well that patients forget they have them. After a while, they need to be taken out. And if they don't, then they can fracture and have just other complications like any other medical device. But since a patient can't feel it, they don't oftentimes remember they have it. And if the patient changes physicians or the physician retires or something along those lines, it can very easily get lost in the shuffle and these things just sort of stay in there forever. So how do we make sure that as physicians, and in particular somebody like myself as an interventional radiologist who places and takes these out, how do I make sure that my patients get these out when they need to? Well, just like we've been talking about on imaging, these things are seen on a CT scan, which patients have pretty much every time they walk into the emergency department. So using a regular image processing algorithm, one that I guarantee every computer science undergrad here on campus learns during their studies, we can create a kind of a template image of what those filters look like. We can process the CT scan in a way that optimizes our ability to automatically detect those filter images. Using a relatively straightforward scripting algorithm, again, that any computer science undergrad would be able to write probably in their sleep, we can automatically detect if a filter is present in this CT scan, identify where it is, and shoot a little email to that patient or to that patient's provider to say, hey, do you remember that you have this? We need to take it out. The reason, and in fact we can do that very accurately. The first version of this that I wrote had a sensitivity and specificity of over 80%, and that's only gone up in the couple iterations that I've done since that time. So why do I give you this example of something that I'm working on? It's not a big fancy company. It's not going to change the whole world of patient care or anything like that. It's because I can do this on my MacBook, number one. And number two, it doesn't involve this high-level supercomputer artificial intelligence. It's just standard image processing algorithms that we already have available to us. And so while this whole talk is a little bit about AI and artificial intelligence, deep learning, that sort of stuff, really there are a lot of different ways in which technology can start to improve our patient care without having to be done by some fancy Silicon Valley technology company. They can be done by anybody in this room by just thinking of a problem, breaking it down into solutions that are manageable, and then actually trying to implement those solutions. So there are some potential successes out there where AI has already made it into the clinical world. Back in 2013, a company got FDA approval to help radiologists interpret mammograms that women have almost every year. This technology was basically just a software that would put a little circle on an area of the mammogram and say, did you look twice at this area? Just to help the radiologist make sure that they weren't missing something. Now, unfortunately, I can say this from personal experience, this was a little bit premature. It became the boy who cried wolf. It over and over and over again, we're putting these little circles on the mammograms when an experienced radiologist would say, that is just not something I need to be worried about, or that the patient needs to be worried about. And so fairly quickly, radiologists started ignoring it. But already in 2013, it was in the clinical world. It was a commercial package that many software developers or software device makers included in their packages. More recently, just last year, the FDA approved a way for an algorithm to try and detect diabetic retinopathy, a particular type of blindness that goes along with having diabetes, from ophthalmology images. And just earlier this year, a company got approval, FDA approval, to start interpreting brain MRIs to understand if a patient was at risk for developing dementia, and if so, what part of their brain was likely to be most impacted by that. This is all done automatically in a way that's augmenting the physician that's already there, but again, this has gone through the approval process and is in the clinical world. So we're making some strides. I think that this is exciting, even if it's relatively limited at this time. But despite these successes, I definitely want to talk a little bit about times when it's touted as a success, but it might really be a failure. This was actually a really interesting article that was published in Archive back in November of last year. And the authors wanted to do something really cool. They wanted to have an artificial intelligence algorithm look and see whether a patient had a hip fracture by their x-ray. So a patient comes into the emergency room, usually an elderly patient, they've fallen, they're having some hip pain, and the emergency room physician, nurse practitioner, whoever, needs to say, does this patient have a hip fracture? If so, of course, they're going to get treatment for it. If not, let's get them back to their home in a somewhat timely fashion. So the authors did some really cool stuff. They developed this neat algorithm where the algorithm itself processed the x-ray image, it took in the patient demographic data, it looked at some other stuff from the patient's chart, it did a deep analysis using a convolutional neural network and some other big fancy words that go into the artificial intelligence framework, and it spit out a result. And for those of you who are used to looking at it, it generated this ROC curve that looks beautiful. So of course it's a hugely successful algorithm, right? Well, these authors were smart. They asked the follow-up question of saying, how did the algorithm figure out that this patient had a hip fracture? What was it actually looking at? And they found something a little bit surprising. They found that there were two key features that the algorithm was looking at to try and make that determination. The first one was the patient age. That's pretty reasonable, right? Older people tend to fall and have their hip fractures a little bit more. Younger people tend to have sturdier bones, and probably not. But the second one was the model of the x-ray machine that was being used to take the picture. Now, that doesn't make a lot of sense to me, right? Why would the model of the x-ray machine have anything to do with whether the patient had a hip fracture or not? Well, when you delve down a little bit deeper, you start to realize that sometimes it's the decisions that are made before the algorithm that are important rather than the algorithm itself. Most hospital systems have two models of x-ray machines. A fixed model that takes a little bit better pictures, and the patient comes to the machine. There's another model that's portable, it's on wheels, and you bring that x-ray machine to the patient. And as you might imagine, since the fixed model takes better images, a healthier patient, a mobile patient, a younger patient gets brought over to the x-ray machine. An older patient, a frailer patient, a sicker patient, the x-ray machine gets brought to them. That's the decision of the healthcare provider, the physician, the nurse practitioner, the physician assistant. Well, if the patient is sicker, frailer, older, they're more likely to have a hip fracture. So this algorithm wasn't even looking at the image. It just said if the patient's old and can't come to the x-ray scanner, we have to bring the x-ray to them, they probably have a hip fracture. If they're young and they're mobile enough to come to the x-ray machine themselves, they probably don't. So this ROC curve is great at the population level analysis. It did nothing for actually predicting on any individual patient whether that patient had a hip fracture or not. So this is a circumstance where those statistics can really lead you astray. This is not a success of artificial intelligence, it's a failure. But it's not a failure because the algorithm was wrong. It was a failure because it was designed overall in a way that didn't necessarily reflect the actual data that we thought it was reflecting. It was reflecting things like the healthcare provider's interpretation of the patient themselves, things that really didn't add much to the patient's clinical care. I wanted to cover one other aspect of it because this was an article that was actually just published about 3 weeks ago and I thought was really interesting. It was published in Science, and it talked about ways in which healthcare artificial intelligence algorithms might be hacked. But I don't want to focus on that part because I think the same concepts can apply as it being a failure rather than being hacked. This is a dermatology image that the algorithm was trying to predict whether it was benign or a malignant lesion, cancer or no cancer. At this point right here, it said very confidently, there's no cancer. But by adding a little bit of noise, just noise to the image, so little noise that if you or I looked at this, or a dermatologist looked at this, we couldn't tell the difference between the two. All of a sudden, the algorithm switches 180 degrees and says, this is malignant. That's a little bit scary, right? Two things that from our interpretations are exactly the same can flip this algorithm one way or the other. Go simpler than that. Take the same image and rotate it by 45 degrees. Benign to malignant. And it doesn't just have to be imaging. There are some algorithms out there where the goal is to predict whether or not a patient is going to get addicted to opioids. Well, if the medical provider said the patient has a history of back pain and chronic alcohol abuse, well, that patient is going to get addicted to opioids according to that algorithm. But use a little bit of medical synonyms. Oh, the patient has lumbago instead of back pain. They have alcohol dependence instead of alcohol abuse. Well, all of a sudden now they're a low risk for opioid abuse. Again, very small changes producing dramatic differences in the output of that algorithm. And finally, even medical coding, which is probably one of the most boring things out there. Something called metabolic syndrome, which is just a combination of high blood pressure, high cholesterol, and high blood sugar, can be grouped as metabolic syndrome or separated out when it comes to medical coding. Well, in one case, reimbursement was denied based on an artificial intelligence algorithm. In another case, it's approved. So I don't give these examples because I'm particularly worried about healthcare artificial intelligence algorithm hacking. I think that's certainly going to be something that people are concerned about, but I wanted to present it as a way to say, would you trust these algorithms if a small little tweak to that input produced such drastic output? And unless we can peer down and understand how the algorithm is making those decisions, I'd be really nervous about incorporating that into my practice. And I think as patients, most people would say, I don't really trust that guy. So this is sort of another area where, again, I think it's a failure masked as a success. So what are some of the biggest challenges that AI faces as it's trying to make its way into the clinical world? I think that right now, the expertise in the medical world and expertise in AI rarely overlap. Both of them are super duper subspecialized and require years and years of training. So to truly have a great understanding of both is relatively rare. And unlike what Silicon Valley has done with many, many other industries, you can't move fast and break things when it comes to healthcare. You can do that when it comes to not self-driving cars, that's another one you can't. You can do that when it comes to things like ride sharing. You can do that when it comes to the hotel industry. You can probably do that when it comes to social media. But when it comes to things like self-driving cars and in medicine, people get hurt if you move fast and break things. So the innovation is much slower and has to be much more kind of controlled than it does in other industries. I think we need to be able to peer down into how those decisions are made. On both the last two slides where I showed you those failures marked as success, I think this is a problem. If you don't really have a good understanding of how the algorithm is making its decision, we're not going to have a good idea of whether that decision is actually appropriate or whether it's being made on something that doesn't even have clinical relevance. And very importantly, I think we need to develop an acceptable failure rate for AI. This is true in the self-driving car world as well. Every time a Tesla gets into an accident with autopilot on, it's all over the news media, right? But what about the 10 accidents that happened here in Eau Claire this morning? We don't hear anything about those. And so this idea that there's going to be a failure rate, and we need to figure out what's acceptable. Even in the medical world, before the late 1990s, up to 1 in 4 patients who a surgeon took to the OR to get their appendix out had a normal appendix. That was just accepted as normal. Now that's improved over the years because of a lot of the other technologies, but we recognize that humans are fallible, and we at least need to start having the conversation about what are we going to accept when it comes to artificial intelligence algorithms. And not just a failure rate, but what failure modes, what errors or complications. It's a little bit different if the algorithm says, well, I prescribe this drug at a slightly higher dose than what the physician or nurse practitioner would prescribe. That might be an error that we're able to tolerate. But if the error results in a patient death or a significant other morbidity, we might not be able to tolerate it as much. So all these things really need to be worked out before we can truly understand whether that algorithm is going to be appropriate or not. So, some ideas that are my own and how I think we need to go forward to truly develop AI in medicine. The first, and I know this sounds really self-serving because I'm a physician, but I think these algorithms need to be designed to augment healthcare professionals rather than replace. I don't think healthcare professionals are in some special category. I think everybody's job is going to change over the course of the next few decades with artificial intelligence and technology. But the goal shouldn't necessarily be from the get-go, replace. I think there is so much expertise out there, and importantly, there are so many areas where all healthcare professionals need a little bit of improvement in either their efficiency or their knowledge or things like that, that there are a lot of gaps that artificial intelligence can fill and really make quicker improvements into patient care before they get to the point of just replace. Number 2, I definitely think that early on, we need to avoid patient-facing patient-facing implementations of healthcare. People are already really frustrated when they go see their physician and the physician is sitting there typing on the computer and not looking at them. The idea that this might increase that or reach a point where they don't even see a physician or other mid-level provider at all, I think would be very frustrating to patients. And once a patient is frustrated by that situation, their tolerance for that error I talked about is going to go down even further. So I think early on, most of the implementations need to be behind the scenes so that patients know that it's there, but they're not directly interacting with that healthcare AI. And I think avoid trying to create this Skynet, this all-encompassing artificial intelligence algorithm is going to be important. It's very difficult to train one individual thing on all of medical knowledge. I mean, I went to 13 years of school after I graduated college to be just an interventional radiologist. Now there's dermatologists and gastroenterologists. I mean, every specialty of medicine is so deep now that I think suggesting that one artificial intelligence algorithm is going to rule them all just is not a good way to go forward. Instead, in my opinion, the better way to do it is to take a Henry Ford-like approach, where break down the medical pathway that a patient goes through into a bunch of little steps. Now, it doesn't have to be like an assembly line where they're all done in series. They can be done in parallel. But little nuggets, I think, will be a much more fruitful way forward rather than, again, this sort of all-encompassing artificial intelligence. And importantly, beware the lies of statistics. By being in the academic world, you guys are already way more familiar with statistics than probably the average person is. But every time you see a headline about artificial intelligence doing XYZ, in medicine or not, remember that academics have an incentive to publish, and companies have an incentive to get their name out there and make headlines. And a lot of times they either, I don't want to say fudge the statistics, but maybe they use statistics that are to their own advantage and don't actually reflect things that are going to be clinically important or important in the real world. And sometimes maybe they're just reporting statistics that don't get down to the nature of the problem. Think back to that hip fracture study I showed you before. If somebody just published that ROC curve, it looked like their algorithm was great, but hiding down behind it would be the real data. And I think we just all need to be really careful to recognize that there are ulterior motives when it comes to getting companies or even academics' names to the forefront. So in summary, in my opinion, AI in medicine is still a little bit more hype than reality. I'm very optimistic going forward that things are going to be improving and improving relatively quickly, but we're not there yet. To show you, however, how fast things are moving, literally yesterday, the FDA released a white paper talking about how artificial intelligence algorithms that are already in the clinical setting might be improved without having to go through a whole new approval process. Basically, how can we iterate on these things rapidly to make sure that we're still making progress without necessarily causing negative impacts to patients? Again, this was released yesterday. I think a lot of the challenges that we're going to face might actually be more psychosocial than truly technological. Things like, what are acceptable error rates? How do we incorporate them into a clinical setting where we still want to maintain the face-to-face interaction of the healthcare professional and the patient? Those sort of things. That might be as big of a challenge as any of the actual technological ones. I do think that successful AI is going to be a bunch of small routines rather than this kind of overarching, again, sort of universal intelligence that might be able to answer all of our problems for us. But I wanted to finish with this quote from Bill Gates that I'm sure most of you have seen before, but I think is so appropriate both to our whole society right now, but specifically to the artificial intelligence that I've been talking about today. And that is, we always overestimate the change that will occur in the next 2 years and underestimate the change that's going to occur in the next 10. I think that's true for so many things. I'm really, really optimistic, and I'm confident that medicine is going to look very similar 2 years from now to what it looks like today. But I'm almost equally confident that medicine 10 years from now is going to look a whole lot different than what we see today. So thank you guys so much for your attention, for inviting me here. Really an honor. Have a good rest of your day. I'm happy to take any questions.
So I'm in the library, and when we talk about algorithms, we're usually thinking about search engines and that kind of thing, and we know that the algorithms greatly impact and sometimes bias the results that we get, and the challenge is that those algorithms are hidden to us. They're usually proprietary, and we don't see them. So when you talk about understanding the algorithms in the medical field, how does that work? Do you have access to those algorithms?
So that, just to repeat the question, basically how do we truly get at some of the lower level concepts of these algorithms that are being developed, oftentimes by a proprietary third-party company, to make sure that they're doing what they actually say that they're doing? I think there's sort of 2 layers of answers to that question. One of them is regulatory, and one of them is just the way that different health systems are behaving. So the regulatory one is that the FDA, both in that white paper I showed you as well as in their other approval process, basically requires the release of nearly all of the source code of their information. Now, it's not quite to the level that I think some people would like, but if they can't actually show exactly how a decision is being made, right now the FDA is not really allowing things to move forward. So it really is a regulatory environment that is keeping that in the way that we want it to. I think you can argue that unfortunately is always liable to shift with the political winds. And so hopefully that will be on the more conservative side. I want AI to move forward and to be a part of the clinical world, but I would much rather be able to be confident that an algorithm is doing what I want it to do. On the health system side, I can speak only from my experiences at Mayo, but Mayo is super conservative about those sort of things. So when it agrees to partner with third-party companies to try and either develop or bring in an algorithm, it basically mandates in its contract, we are going to be able to look at every little aspect of this. And part of that is a medical legal framework. You know, in general, when these technologies come in, they're not the ones who assume the legal risk if something goes wrong. It's the physician and the healthcare organization. So, and Mayo is particularly conservative with some of those things. So it really makes sure that, hey, if we are the ones acting upon the information we're getting, and we are going to assume that medical legal risk, and we want to do what's best for the patient, we need to make sure that we're confident it's doing what it's going to say. I think that is going to be another big challenge going forward, though, as more and more proprietary Silicon Valley companies join the fray of AI.
I have a question. So when AI first kind of started to be talked about in medicine, I heard a lot about natural language processing and how it was going to revolutionize documentation. You know, we spend so much time documenting, and then I don't really hear as much about it anymore. What is kind of the state of AI and assisting with documenting?
That's a bigger question than I even think we have necessarily time to talk about. So NLP is great in the sense that it can really parse what is already there and try to extract some important pieces of information. But what it doesn't do is then restructure it in a way that humans can kind of take in themselves. So clinic notes are something that every nurse, every physician, every pharmacist, basically everybody puts into the chart as a way to summarize their interpretation. And while a computer can parse that to pull out some important pieces of information, it doesn't have anything to do with that. This is getting a little bit off topic of your answer, but most medical records now, even though they're electronic medical records, are electronic paper medical records. There's been very little improvement upon paper charts other than the fact that you don't physically have to hold a piece of paper and you can log in from any piece of computer or any computer workstation. But they're structured the same. So the same limitations that we have on paper, we have with our electronic medical record. And so I think with the original hype with natural language processing was that we wouldn't have to read a 3-page clinic note anymore. When a patient saw a physician, saw a nurse, saw whoever, that would be summarized in some little bullet point or whatever automatically, and then everybody would be able to look back in a much more concise framework than they had been doing before. And I think the reason that hasn't played out is not because of the limitation of natural language processing, it's the limitation of the way our electronic medical records are designed. They just don't have a way to summarize that data. And every time they do, it becomes dirtier and dirtier and dirtier. If any of you guys ever have seen the cartoon called XKCD, it's basically a technology cartoon that makes jokes about how technology actually only complicates our lives. One of them was complaining about a bunch of different standards that are out there. And they said, I hate all these standards, I'm going to develop a new one. And then the next pane in that cartoon is, now there are N+1 standards out there. And I think that's what ends up happening in the medical record is every time there's a new idea, instead of replacing and condensing the medical record, it only expands it further and further and further. And so now instead of a patient's chart being this thick, it's a terabyte of data, and if you printed it out, it would be this thick. You get the copy and paste errors and all these other sort of things. So I know that was a really long answer, but I think the technology is there, but what has not caught up to it is the way that we interpret that electronic medical record as medical professionals.
I'm curious, coming from an institution, an educational institution, you were saying that there's two paths of the medical side and the AI side, so the computer side. Are there programs being set up in the country that actually are starting to train students to integrate the two?
Yes, but I think it's a lot of times ad hoc. And so I can give you kind of my own example is that I did a lot of computer science when I was an undergrad, and as a graduate student, kind of maintained my interest in that area. So even when I got into medicine, I sort of knew that I wanted to keep at least one foot in that area because I liked it so much. Well, I got far enough up where eventually there was some desire for somebody to have that kind of experience, and I got some educational time dedicated into my training pathway for combining those two. But it didn't happen until way down the road. It wasn't like I was a late undergrad and said, I want to be an expert in this. Where's a training program that can give me both pathways of expertise? I had to sort of do one and then do another, and then it was sort of like it came together, but not in a very controlled way. From what I've heard, the only real places that are doing that are out on the West Coast. So your Stanford, your UCSF. I think Carnegie Mellon in Pittsburgh is also kind of at the forefront of this, where they recognize that these, and it's not just medicine. It's basically AI and whatever. They recognize that to really be able to move artificial intelligence into these other industries, you have to have dual training. And I think those institutions have a lot of foresight in recognizing that you can't go all the way into one and then expect to just step over into the other one. You really have to train in parallel. And so I think it's just starting, but there are some institutions out there that have that foresight. Thank you all again.